said, first of all, welcome. We are so glad you're here and that you're so glad that you've got an interest in health protection. Please, if you haven't already done so, turn off your camera and your microphone, please. There's so many others on the call, it can interfere with the sound quality. If you do have a question, type it into the chat function and Joe and Raj will pick up on them and let me know. The session is going to be recorded, and that's so we can put it onto the website along with the slides so people can look at it later on. So if you don't want to be recorded, you might want to type your question into the chat function rather than ask it. Sorry, and there will be, as Joe said, opportunities for you to ask questions, but do use that chat function. So that's just a little bit of housekeeping to get that over and done with. So what we're going to cover today, and it's quite a lot, so it's going to be quite a superficial covering into health protection, but this is really an introduction session. So what I'm going to do is I'm going to introduce the training that we've devised and give you a bit of an overview about how that will work. Also, I'm going to touch on some key health protection concepts, and it's very much an introduction. You will get much more in the future, more in-depth modules. So hopefully you'll finish this session thinking, that's really interesting, I'd like to know more about it. And if you feel that way, then I've achieved my aims. What you won't do at the end of this session is think, aha, I know everything there is to know about health protection, because it really is an introduction to quite a lot of topics. And what we're going to look at is, why are you here? Why are you listening to me? What is public health? Now, a lot of you on this Teams call work in public health, so you know far better than I do what public health is, but not all of you do. So I'm going to do a very quick introduction to public health, and it will be the quickest covering of public health you'll ever get in your life. It will be very quick. And then we're going to move on to health protection and what it is. There'll be a little bit about the history of infectious diseases, because it's directly relevant to what's going on at the moment with COVID-19. We're going to look at some of the current health protection issues. We're going to look at notification of infectious diseases very briefly. We're going to look at public health emergencies of international concern very briefly. And then we're going to do a basic session about COVID. So this is quite a lot to get through, but as I say, it is going to be quite superficial, and you are going to get more details on all of these things in future sessions. And there's also online training. So some of you will have received the training package booklets. Some of you might not have had it yet, but you will all get it by the end of the day. And there's loads of links to online training in there. So if there's something that you're particularly interested in, you can follow that up yourself. So that's what we're going to be doing in this session today. So why are you here? Why health protection training? Some of you may be very interested in it. Some of you, it might be something you're not really very aware of before COVID hit. And so really the reason why we've brought you all here together and to do this training is to help out to some degree or other with our COVID response in Sandwell. So at the moment, sorry, excuse me, I don't have COVID-19, I just have a bit of a cough, so I do apologise for my sore throat. So at the moment, the COVID-19 response in Sandwell is pretty much as you can see here. So we have a Director of Public Health, Lisa McNally, and basically she's the boss, she's in charge, she's leading the public health response to COVID. As Director of Public Health, she's responsible for the health and well-being of everybody who lives and works in Sandwell, which is a pretty heavy responsibility. So she leads up on that. We've then got underneath 3 consultants in public health, some of whom may be on the call now, Annie Calm, Paul Fisher and Tanith Palmer. And then there's also myself. I'm not a consultant in public health, but I am a nurse consultant in health protection. So the 4 of us are working at consultant level in health protection. We've then got Linda Farley and Claire Jones, who are 2 infection control nurses, and they've worked with us doing some brilliant work. And we've got some information officers, Caroline, Pam, Naz, Shirley, Asher and Cherie, who've really helped us out. And also the intelligence team, Nathan and Richard in particular, who've done great work. But there is a gap. This is a marathon, not a sprint, and COVID is not going away. And we need to have more capacity. And we need capacity in two main areas. We need people who we can train up to give health, so they can give, with some supervision and support, can give health protection advice. And also we need people who can act as information officers. So really the reason why we're giving this training to all of you is to try and support this public health COVID response. Now there's two main roles, there's two groups here. And both of these groups are going to be absolutely invaluable in the COVID response, and both groups are equally important. So group one is the much bigger group. Most of you listening to this, we are hoping to recruit you into health protection information officers. And the role of the information officers is to contact people, to gather data about COVID, to record that data and then to report back to somebody. So people who are information officers, you're not giving advice. We don't expect you to give advice, but we do need you to help us, and it's a critical role in fighting COVID. Group two is a much smaller group of people. Very few of you are in group two. If you are, you already know about it because your line manager has spoken to you. And this is a much smaller group. And the idea is that these people are going to train you up. So we'll give you the knowledge and the skills and the support that you need so that you can help by giving health protection and infection control advice. And the idea is that you'll cover the public health COVID inbox with support. And so it's a kind of more intensive training, but it's giving more advice and more of an expert role. And as I say, both groups are equally important. It's just a different role. And this could be in anything. At the moment, we don't know how this is all going to play out. When COVID first started back in February, March, the schools were the biggest amount of our workload. Then that eased off a bit and the care homes became the real challenge. The care homes are getting a bit better now, and workplaces and schools are becoming a problem again. It could be contact tracing. So health protection is it's not set in stone. We can't say that in 6 weeks' time you will be working on schools or you will be working on contact tracing, because we just don't know. We just have to wait and see how this pandemic folds out. So really, we're so grateful that you're interested and that you've offered your support. And whether you're going into group one or group two, a massive thank you from everybody who works in health protection, because we do need you. So this brings us on to the training. We obviously can't and won't throw anybody in at the deep end. We're going to give you all the support that you need to do whatever role that it is that you're doing. And we've come up with this training package to help support that. And there are 13 modules in total. And the earlier modules, the idea is that the earlier modules give you the basics. So this is a complete whistle-stop tour of health protection. You'll get a bit about microbiology and immunology next week. You'll then get a little bit about vulnerable groups, who's more vulnerable to infections. And then the training will move on, and as the weeks go by, it will become more detailed, and you'll cover things like personal protective equipment, risk assessments, contact tracing, and how to investigate, manage an outbreak. So by the end of it, you'll have covered an awful lot, and the idea being that will equip you to do the roles that you need to do. There are taught sessions. There are never going to be more than 2 taught sessions in a week. So some weeks it will just be 1, like this week. Some weeks, like next week, you'll get 2 sessions, but it's never more than 2 in a week. And there's also online training that you are encouraged to do, and training in your own time. Now, not everybody needs to attend every module. Some of you might be looking at this thinking, oh my goodness, I don't have the time, I just don't, I can't do it. And that's fine. You're all very welcome to attend all 13 modules. We're never going to turn anybody away. The more people that know about health protection, the better, as far as I'm concerned. But those of you who are in group 2 and you've had a chat about this with your line manager, we do expect you to attend all 13 modules, because you need to have an understanding of all the things that we're covering in order to be able to give the advice and support. Those of you who are in group 1, you're very welcome to attend all 13, but you don't have to. And the modules that are ticked in red are the ones that we do expect you to attend. If you want to help us out in that role, we do need you to cover those modules. These slides are going to be available, so you don't need to start scribbling all of this down. And the training package workbook that will be sent out covers this as well. So that will be made clear. And as I say, everybody is very welcome to attend. There'll be some of you on this session who won't be doing either of the roles. You're just here because you're interested, and that's fine as well. You know, the more people that know, the better. And also, for those of you who are in group 2, we're going to have a facilitated session every Friday. We can't offer it to everybody, I'm afraid. I just don't have the capacity. But for people who are going to be trained up to be health protection practitioners, every Friday we'll have an hour session that you don't have to attend, but it's useful to reflect and to share learning and to bounce ideas off each other. So that really is the structure of the training, and this will go on into, I think it's the middle of August. So does anybody have any questions so far about the training or the modules?
Nothing on the
Fantastic. So those of you who haven't had the workbook, you'll have all had it by the end of the day or tomorrow at the absolute latest, and all of this information is in there. So, public health. Not all of you, some of you work in public health, some of you don't. So I'm going to give the briefest of introductions to public health. It really is very quick and dirty. Public health, it can be defined in many ways, but I quite like this one from 1920, and it talks about the science and art of preventing disease and prolonging life and promoting human health. And that's done through organised efforts and informed choices of society, organisations, communities and individuals. And I think what's important about public health is that we're looking at the population level, not about individuals. Healthcare is often about the individual. Somebody becomes unwell, they have an operation, they get better. Public health, we're looking at communities and populations. And that could be the population of Sandwell, the population of the West Midlands, the population of the United Kingdom. It varies. 3 domains of public health. So there's health protection, which is what we're going to be discussing in much more detail. And health protection is really about protecting health, looking at the environment, workplaces, investigating health problems and enforcing laws and regulations. And I know that there's some environmental health colleagues who are dialing in, and a lot of your work is obviously around enforcing laws and regulations to keep people safe from food poisoning and other issues like that. So that's one of the domains. You've got health improvement. This is about improving the health of the population. So informing, educating, empowering, monitoring health statuses. It might be through losing weight, through stopping smoking, through fitness and exercise, but we're trying to improve the health of the population. And then the third domain is about health services and making sure that we have got health services that we need, that meet the demand and the need of the local population, and that the people who need the services are able to access them. So all 3 domains are equally important, but really I'm not going to talk any more about health improvement or health services because that's not what we're here for. So what I'm going to do now is move away from public health. And as I said, that is the quickest session on public health you'd ever get in your life. And I'm going to move on to health protection. So what we're going to cover in this session is a little bit more about what health protection is. There is going to be a quiz, and what I'll do is I'll get you to turn your microphones back on for the quiz so you can shout out the answers. Then there's going to be a bit about the history of health protection and infectious diseases, because not only is it absolutely fascinating, it is very relevant to what's going on at the moment. We're going to look at some current health protection issues, and quite obviously the biggest issue at the moment that we're all very aware of is COVID-19. So that's what we're going to be covering really for the rest of this session. Does anyone have any questions so far? Fabulous, I'll take that as a no. So what is health protection? So health protection, there's really three main aspects of health protection. So a lot of what we do, I'd say most of what we do in health protection relates to infectious diseases. Obviously COVID-19 is the biggie at the moment, but there's so many others. So flu, influenza, tuberculosis, measles, all of these things are very current health threats and take up a lot of time of people working in health protection. There's also a lot about emergency response as well. So obviously there's an emergency response going on at the moment to COVID-19, but if there was a flood or a fire or a chemical spill or a massive crash on the M5, health protection would be involved from an emergency response point of view. And then finally, there's environmental threats. That could be through land contamination, that could be through flooding, that could be through heat waves or very cold weather. So really health protection is quite a broad domain of public health, but really most of what most people do working in health protection is infectious diseases, and as a result that's what I'm going to concentrate on. I'm not really going to look too much, well, I'm not going to look at all emergency responses or environmental threats. So what you'll be getting today and really throughout the 13 modules, it's very focused on infectious diseases. If you are interested, that there are some online training links to the more environmental threats to health, and I do encourage you to look at those as well. And it's important to notice that disease is not just about the bugs. We tend to think about diseases and it's all to do with the virus or the bacteria, but it's more complicated than that. So how susceptible we are to disease depends on three factors really. So it depends on us as a host. So our age, our sex, our gender, our genetic profile, where we live, our immune status, all of these things to some degree or other influence how susceptible we are to disease. So somebody who's 90, for example, is probably going to be more susceptible than somebody who's 21. The agent itself is obviously very important, and from an infectious disease point of view, we're really looking at bacteria and viruses, but it could be a poison, it could be radiation, it could be fire. And then the third factor is the environment that we live in. So TB is a really good example. People who live in crowded, bad housing are more at risk of TB than people who live in good housing, which is not crowded. So the environment also has a big impact. So really what I want you to be aware of is that health protection, we tend to focus quite rightly on the virus or the bacteria, and of course that's important and we need to understand them, but also us ourselves as the host and the environment that we live in all play a part to play in how susceptible we are as individuals or as a population to disease. So health protection quiz. So if everyone can turn your mic on so we can hear you. Fantastic. So I'm going to ask you a few questions. And what I want you to do is when I say the answer that you think is right, shout out yes. So we'll see which gets the most yeses. So question number 1, which public health protection measure has saved the most lives? Is it number 1, clean drinking water? Shout out yes if you think it's clean drinking water.
Yes.
Yes.
A few yeses for that. Or is it 2, vaccination? Absolutely spot on, clean drinking water. Vaccination has saved millions of lives globally. It really has. But clean drinking water is probably the single most effective public health measure that has ever been introduced globally. And of course, it's sobering to remember that there are many people today on the planet who do not have access to clean drinking water. So yeah, good, doing well so far. So question 2, how is hepatitis A virus spread? So is it through sexual contact? Shout yes if you think it is.
Yes.
So a few yeses. Contaminated food, water? Shout out yes.
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 A few more yeses. Is it airborne? Okay, good. So that's a slightly trick question because it's actually sexual contact and contaminated food, water. So yeah, sorry about that. That's the last trick question. So hepatitis A is a virus that causes inflammation of the liver, and it is mainly spread through contaminated food and water, but it can be spread through sexual contact, especially among men who have sex with men. So yes, spot on. And next question, we can get flu from the adult flu vaccine. Is that true? Is that false?
Yes. True.
Absolutely false. So the adult flu vaccine is not a live vaccine. It cannot possibly give anybody flu. It can't give you flu any more than it can give you cholera or rabies. So correct, it can't give us the flu. And then final question, rabies is 100% fatal. Is that true? Is that false?
False.
Yes.
It's true. Oh, and I threw that one in there because that's actually incredibly unusual. Most diseases, well, I think somebody might correct me if I'm wrong, but I think it is the only disease really that if you develop symptoms, it's 100% fatal. Even diseases like Ebola that have a really high case fatality rate, it's nowhere close to 100%. So most diseases don't kill everybody who get them. Now with rabies, there's 1 or 2 anecdotal reports of people surviving, but really it's a nasty disease that is 100% fatal. So that's just a bit of a fun quiz to set the scene. So if you could all please turn your mics back off again, just so we don't have any interference. And thank you and well done. What I'm going to do now is just do a little bit of an intro into the history of infectious diseases, because it is really relevant to what's happening at the moment, and also to set the scene and give you a bit of an introduction into health protection more generally. I have missed quite a lot out. I've had to because we've only got an hour. So I'm just touching on a few of the key concepts and the key developments, and quite a lot of things I've just missed out. So do bear with me for that. So sometimes we're tempted to think of infections as a new thing, and of course that's really not true. Infections have been with us for millennia, and this image here, it's a hieroglyph on a pyramid from ancient Egypt. And I like it because it shows 2 people and they're tending the earth, and they've got agriculture, and there's a goat or a cow or whatever that is there. And they've got the fields growing with fruit and crops and corn. And really, it's useful to remember that a lot of the infectious diseases that we have with us today are originally diseases of animals, and COVID-19 is no exception. So many of the diseases that we have now that we are concerned about, so flu, for example, or measles or COVID-19, they were originally diseases of animals, and they crossed the species barrier and they affected us as humans. And really this first began to happen with the dawn of agriculture, several thousand years ago. Prior to that, when we were small nomadic bands, we lived in caves, we were very small groups, there weren't enough humans living together for these diseases to survive. Infectious diseases, they like crowds, they like cities, they like people living together in close proximity. So really it was really the agricultural revolution where infectious diseases became a real issue for us, and they've been with us ever since, of course, as we can see today. This image here in the middle, I love this image. Some of you may know what it is, some of you may not. It's a plague doctor. So the Black Death, the plague, it swept through Europe, swept through the globe in the Middle Ages and caused massive outbreaks of infection. And the Black Death is caused by a bacteria. It's called by a bacteria called Yersinia pestis. And of course, back then, nobody knew that. People didn't know about bacteria. That was before we discovered germs. And of course, these things are tiny. We can't see them with the naked eye. So people didn't know what was causing it, just that they could see people dying. Up to a third of Europe died of the Black Death. It decimated society, well, it more than decimated society. It was a third of Europe possibly that was killed. But people knew that you could catch it, and people knew that if you were a nurse or a doctor or a priest going to see somebody who was sick or dying, that there was a risk. And so they wore this kind of get up here to protect themselves. So they wore these heavy robes to cover their body so they weren't being exposed to whatever it was that was causing the disease. And they had the hat on, and they had this beaky thing here. And this was a mask that they wore, and they would stuff it with lavender and herbs that smelt nice, thinking that if they can smell nice smelling smells, that will protect them from the bad air, and that will stop them from getting unwell. So really this is the medieval equivalent of personal protective equipment, which fortunately has changed quite a bit. And what's interesting is it probably made matters worse, because the Black Death, the bacteria Yersinia pestis, is spread by fleas, and this really heavy robe here was probably hoaching in fleas, so actually it probably increased their risk of infection rather than reduced it. And then this image here, so this is Marianne Dashwood from Sense and Sensibility. So if you don't know the book or you haven't seen the films, Marianne Dashwood, she gets her heart broken by Willoughby, and she's broken-hearted, so she goes for a walk in the rain. As you can see here, she's very wet, and she's a fit, healthy, 18-year-old, and she goes for a walk, she gets wet, and she develops a throat infection, and she almost dies as a result. And of course, this was before antibiotics. Antibiotics were discovered in the 1940s. And back before antibiotics, fit, healthy people did quite routinely die of infections that today we would think of as really trivial. So this is just to kind of illustrate that for most of history, we've lived in a pre-antibiotic era, and that infections in the past that now we might not worry about could prove fatal to very fit people. So infections aren't new. They've been with us for a very long time, and pandemics aren't new. The Black Death was a pandemic that killed far more people than COVID has, fortunately. There's also been massive success stories in health protection, and I would argue that smallpox, the eradication of smallpox, is humanity's greatest achievement. And this was done through international collaboration. No one country did this. This was the globe, everybody on the globe working together to eradicate smallpox. And smallpox was a dreadful disease. It had a very high mortality rate. If you caught it, the risk of you dying was very high. Many people who had it, who did recover, were left scarred and with side effects for the rest of their lives. And it was a very highly infectious disease, far more infectious than COVID-19 is. And it was a viral infection, but there was a vaccine for it. And really, through international cooperation and through vaccinating large numbers of people and through contact tracing and through following up people, smallpox was eradicated off the planet. So it doesn't exist anymore. There are stores of it in a freezer in Atlanta, in the Center of Disease Control in the USA, but smallpox is not an infection that exists in the wild anymore. And that was a massive achievement, and it was done through international cooperation, and it was done through some of the concepts that you'll be learning about through this course, such as contact tracing. So it works, it really does. And another success story is TB. Now, TB hasn't gone away, it's still a problem. And prior to COVID, quite a lot of my work was around TB. And certainly in Sandwell, we do have quite high rates of TB, but it's nothing like it was in the past. Now, this graph here shows TB mortality, so people who are dying from TB in England. And it starts off back in the 1860s, and you can see that mortality was really very high, but you can see this lovely downward trend, downward, up until about the 1960s. And if we carried on, it would be even further. So far fewer people are dying of TB now than they were back in the 1860s. So that's a massive success story. But what I find really interesting about this graph is that not only are fewer people dying of TB now than they were 100, 200 years ago, but actually the death rate was falling before we discovered antibiotics. So antibiotics were discovered in the 1940s. So Alexander Fleming, he had some moldy bread in his kitchen and he discovered penicillin. And the only way you can treat TB is with antibiotics. It's a bacteria, you give antibiotics, that kills the infection. You have to be on them for quite a long time. So up until the 1940s, we had no way at all of treating TB. We couldn't. People either died or they got better. There was nothing really we could do about it. But look at this massive decrease in the death rates before we had any treatment. You can see a bit of a blip for World War I, and you can see a bit of a blip for World War II. But really, apart from that, the downward trend was massive before we had any treatment whatsoever. And the reason for this is what it goes back to what I said earlier. There's more to diseases than just the deaths. This is about housing. The housing in the 1950s, the 1940s is far better than the housing was in the 1860s. People, the changes to sanitation, to housing, to better living conditions in that time period was massive. And that's what has resulted in the falling death rates from TB. So really the wider determinants of health, the things like the houses that we live in, the sanitation, the crowding, all of that sort of thing had a massive impact on TB deaths before we could ever treat the disease. So I think that's a really good example of all the things that influence infectious diseases. It's not just the bug itself, and it's not just the antibiotic or the antiviral. And then measles as well. So again, measles hasn't gone away, sadly, but we used to get a lot more measles. So this is a graph showing measles notifications. So measles is an infectious disease. It's caused by a virus, and it's a notifiable disease, which I'll come on to later on. So doctors have to inform about it. And really, you can see that back in the 1940s to about the 1970s, there was anywhere between about 300,000 and 700,000 notifications every year. Some years were worse than others. That's quite common with infectious diseases. They happen in cycles. And then really, as vaccines were developed and as living conditions improved, the notifications of measles decreased. And although it's not gone away and we're not measles free in the UK, it's a lot better than it was back in the 1940s and the 1950s. And that's down to vaccination predominantly. We have a safe and effective vaccine. And it was really looking great. It was looking so positive. We got rid of smallpox, we'd eradicated it. We'd beaten TB by the looks of things. It was looking fabulous. It was the golden era of infectious diseases. And so much so that in 1970, the US Surgeon General said it's time to close the book on infectious diseases. And he said the war against pestilence has been won and we need to shift our resources to chronic problems like cancer and heart disease. And yeah, he perhaps wasn't, wrong in saying focus on cancer and heart disease, but he was absolutely wrong to say that the war against pestilence had been won, because it really hadn't. And then a few things happened. So I personally hate the term superbug, but there you go, that's just me. But antibiotic resistance became a problem. So MRSA, I'm sure you've all heard of MRSA. MRSA is a bacteria called Staphylococcus aureus, which is resistant to an antibiotic. And we first identified it in 1961. And in the 1980s, it caused outbreaks, and it's now endemic. Some of us listening to this will carry it in our nose and in our groin and in our armpits. It can cause real problems in hospitals. It can cause wound infections, and it's very hard to treat. And then C. diff, I'm sure you've all heard of C. diff. Again, it's a bacteria that's resistant to many antibiotics. It was first discovered in 1935. It caused big outbreaks in hospitals in the 2000s, massive outbreaks. And again, it's now endemic. It's not as bad as it was, but it's, both MRSA and C. diff, we've reduced the rates, but we're never going to be able to get rid of it, either of them. Drug-resistant bacteria, I'm not going to say much now because one of the talks next week is about basic microbiology, and I'm not going to go into huge details because it's very complicated, even next week. But bacteria have been around. They were probably one of the earliest forms of life on the planet. Bacteria were here long before humans, and they will be here long after we're all gone. And they're very good at surviving and adapting. And many, many bacteria are becoming resistant to the antibiotics that we use to treat infections. So I showed you Marianne Dashwood earlier on, who almost died of a throat infection after going from a walk in the rain. The risk is that we might go back to those days where we don't have antibiotics that we can use to fight infections. And then there's been further setbacks. So measles is one of the success stories, and we have done really well. But then this man, Andrew Wakefield, published a paper in The Lancet, which incorrectly linked the MMR vaccine with autism and bowel problems. And it was wrong. MMR doesn't cause autism. MMR does not cause bowel problems. We know that. We've proved it. And he was in the pay of the single vaccine companies, so he was getting paid by the vaccine companies that were in competition with the MMR vaccine, if you like. And he committed fraud as well, and he's now been struck off the medical register. He can't work as a doctor. But this man did incalculable harm to vaccination rates, and people stopped trusting vaccines, and MMR vaccine in particular, because of him. And as a result, we've seen an increase in measles since then. And people have died because of that. People are deaf today because they got measles, because they weren't vaccinated, thanks to Andrew Wakefield. So although we've had success stories, it's still very fragile. And one man can actually have a devastating impact on health protection. And sadly to say that Andrew Wakefield is good pals with Donald Trump and is now over in the US. And I think the last I heard was he was advising Donald Trump about the safety and efficacy of vaccines, which is a very scary prospect. And he really had an impact. So this graph here just shows the impact that Andrew Wakefield had. So the gold bars here are percentage of MMR uptake. Now, no vaccine is ever going to be taken up 100%, but the more people who are vaccinated, the better. And with measles, you need about 95% of people to be vaccinated to protect everybody in the community. And you can see what happened was MMR uptake was probably about 92, 93% there, which is pretty good. And then Andrew Wakefield publishes his paper and MMR uptake drops to below 80%. So fewer than 80% of the population were being vaccinated. So vaccine drops, and this blue line here is confirmed cases of measles, mumps and rubella. And you can see that when MMR uptake falls, the confirmed cases of MMR, of measles, mumps and rubella increases. So this is a direct result of that. So we can see that when vaccinations fall, rates of infection increase. So this is the Andrew Wakefield effect. So it had a real devastating impact on people's health. So I'm now going to move away from the sort of the history and the where are we now, and move on to some of the current health protection issues, which will include COVID-19. Does anyone have any questions so far?
Nothing on the chat, Valerie.
Fab, thank you. So this list here is a list of the it's a list of diseases that are notifiable under law. So the health protection regulations of 2010 state that any doctor who diagnoses any of these conditions is legally required to notify the proper officer, which is Public Health England really, about them. So if a doctor diagnoses a case of TB or a case of Legionnaire's disease or a case of food poisoning, they are legally obliged to report these. And it's quite a wide-ranging list. So we can see here that we've got COVID-19 on it. That's the most recent edition. So anyone who's diagnosed with COVID-19, the diagnosing doctor has to report. It's also worth noticing that the labs report these things as well. So any lab that diagnoses, that does a test, a PCR test that diagnoses COVID-19, that gets reported as well. You can see on here that smallpox is on the list, and you might think, well, that doesn't make sense because smallpox has been eradicated. But of course, there's always a risk of the deliberate release. Somebody gets hold of some smallpox virus somehow and deliberately releases it as a bioterrorist incident. And you can absolutely be sure that if anyone ever diagnosed smallpox, we'd absolutely want to know about it as soon as possible. So this is a list of diseases, and it's really important for surveillance purposes because if we don't know how many cases of disease we're having, there's not much we can do about it. So earlier on, I showed you the measles graph. Well, you could see the increase in the cases of measles, mumps, and rubella as vaccine went down, and we knew that was happening because they're all notifiable diseases. And we need to know about these because it's information for action. We can't do something about a disease unless we know how many cases we're getting. And it also allows us to identify outbreaks. I'm not going to talk any more really about surveillance because Neil is going to be doing a session on surveillance later on, which will look at this in much more detail. But really, surveillance is a crucial part of health protection. We need to have really good, reliable, robust information. The data just needs to be good in order to inform what we do. So the final kind of bit about my presentation, and this is very much a whistle-stop tour of health protection, is international health protection issues. And we live on a shrinking planet. You know, we're never more than a 12, 24-hour plane flight away from anywhere on the globe. And that's wonderful because we can meet people, we can see different cultures, we can visit different countries and different parts of the world. And that's a fabulous thing, but it also brings its problems, because it means that a disease that emerges in a wet market in Wuhan is just one aeroplane flight away from anywhere on the planet. So diseases that in the past to spread around the globe would have taken months, if not years, today can spread around the globe in a matter of hours and days. So it makes it a much bigger challenge than it ever was in the past. And as a result of this, the concept of public health emergencies of international concern was developed. And this is the WHO, and the World Health Organization recognise that diseases don't respect national boundaries. You know, diseases don't care that there's a border between the United States and Mexico, or that the UK is no longer part of the EU. National boundaries don't mean anything to infectious diseases. And public health emergencies of international concern, the WHO would declare one of these if there is an extraordinary event which is deemed to constitute a public health risk, and it requires it basically requires international coordinated response. So public health emergencies of international concern, or PHICs, are declared when we need countries to act together to protect the health of everybody on the globe. So that's the idea about this. And there's been a few PHICs declared. The first one was in 2009, and that was swine flu. And some of you may remember that. By the way, a pandemic just means it affects all the globe. You can have quite a mild pandemic. Swine flu, you could argue, was a fairly mild pandemic, although many people did die. But it did affect the entire globe. Polio was declared to be a PHIC back in 2014. It was looking like polio was going to be eradicated, and then through a variety of reasons, it wasn't. And so that was declared a PHIC there. Of course, we had Ebola and Zika virus as well, and both of those were declared to be public health emergencies of international concern. And then the most recent one is the one that we're living in the middle of now, and that's COVID-19. So that requires international cooperation. We can't work in silos. We all need to work together as a globe, as an international community to beat COVID-19. So, excuse me. I'm just going to finish off this session and hopefully with some time for any questions at the end, with a bit of an introduction to COVID-19. This is a very basic introduction. There's going to be a session later on about COVID-19, which will look at it in much more detail about the epidemiology, how it's spread, potential possible treatments or vaccines, that sort of thing. So this really is just a very brief introduction to set the scene. Incidentally, that's what it looks like. It's called, COVID-19 is a type of coronavirus, and they're called coronaviruses because they sort of look like crowns. They're quite pretty. That's what they look like under the electron microscope. So people talk about coronaviruses and then they talk about COVID-19, and people often use the two interchangeably. But coronaviruses are just a group of viruses, and there's lots of different types of, or there's lots of different viruses that are coronaviruses. Now, we've all had a coronavirus because many of the viruses that cause the common cold are coronaviruses. And we've all had a cold, and we felt pretty miserable with them. SARS, so some of you will have heard of SARS, which was a real concern and worry back in 2002, 2004. SARS is a coronavirus, as is Middle East Respiratory Syndrome, MERS, and that first emerged back in 2012. And it's a very severe disease, as is SARS, but doesn't appear to spread that well. So although it causes very severe disease in the individuals that get it, it doesn't spread easily at all from human to human, although it has done, but it's much less infectious. And then the disease that we're all concerned about at the moment the disease is called COVID-19 and the virus is called SARS-CoV-2. So coronavirus is a group of viruses. SARS-CoV-2 is one of those viruses and it causes the disease COVID-19. So COVID-19, as I say, it's a viral infection. It's caused by the SARS-CoV-2 virus. Symptoms, they vary. Obviously, and it's important to recognise this is a new disease. We're still learning about it, and things will change the more that we learn. But at the moment, the main symptoms are a high temperature, so a temperature of 37.8 degrees C or higher, a new continuous cough, or a loss or a change to the sense of smell or taste. The word taste has been cut off there, I'm afraid. Sorry about that. And it's caused by the SARS-CoV-2 virus, which looks like this. And I'm going to go into a little bit more detail about this in a session next week, but I'm not going to go into too much detail because it's incredibly complicated and we don't really need to know that much detail. And it's spread through droplets. So as we talk, as we sing, as we cough, as we sneeze, we all release droplets of respiratory secretions into the air. And those droplets contain this virus. And then another person can inhale them, can get to ingest them via contact. So the virus spreads from one person to another through these respiratory droplets. And I find this timeline really helpful because everything has happened so quickly, and you know it's July now. It's what is it? It's the 2nd of July, and December 2019 seems like so long ago. So much has happened, but really it was on the 31st of December last year that China reported the first cases to the WHO, and at the time it was an unknown cause, and this was back in 2019. And then on the 12th of January, so really only 12 days later, the novel coronavirus was identified, which was later turned out to be COVID-19. In January, we had the first person-to-person transmission identified outside of China, and that was in Vietnam. And we also had the first confirmed case in Europe, and that was in France. And then on the 31st of January, we had the first 2 confirmed cases in the UK. In the 1st of March, we had a family cluster of cases, and at that point we had 35 cases in the UK. So on the 1st of March, we only had 35 cases, and that's obviously a lot more than that now. The WHO declared it a pandemic on the 11th of March. So on the 11th of March, they said this is affecting all the globe. Every part of the globe has been affected by COVID-19. And then on the 23rd of March, the UK government implemented lockdown measures. And this is an epidemic curve that I've taken from Public Health England. And really, this is showing number of cases. So it's number of cases up on the side. It goes up to, I think that's 30,000, no, 300,000, yeah, 30,000. And really early on, we were seeing 2, 11, 4, 7, 61 cases. And then you can see that the number of cases really started to dramatically increase, but it's tailing off. What we're worried about is if there's a second wave and we start to see another increase. And I'm going to talk about this sort of thing in more detail in the COVID-19 session later on in the modules. This is a similar graph, but it's showing the number of outbreaks. So this one is the number of individual cases, and it goes up to 27,870. This here, however, is outbreaks, and you know this is the winter. So this is week 52 is the last week of 2019, and then we go into the first week of 2020. So this is last winter, and the outbreaks that you can see there, the blue ones are schools, the kind of brick red ones are care homes. This is flu. This is flu and flu. So it's acute respiratory outbreaks. So basically what we're seeing here is seasonal flu. This is influenza. And that's normal in winter. We get flu in winter. It's what happens every single winter. And then you can see that what's happened is we've pootled along and we're getting around to about week 12, which is March, of course, and we can suddenly see the number of outbreaks massively increasing. And most of them are in this red colour. Most of these outbreaks are in care homes. So care homes were absolutely massively hit by COVID-19. It's been a real tragedy, actually, what's happened in the care homes. There's been many deaths. The excess all-cause mortality in care homes is really high. Far more people have died in care homes than we would have expected to. And we can see here that although there have been some outbreaks in hospitals and in schools, the vast majority of the outbreaks in England have been in care homes. And the good news is it's tailing off. We're now seeing fewer outbreaks in care homes, but we're now that the schools have reopened, we're seeing more in schools. But again, what we're worried about is if it starts to go up again. So we're keeping a very close eye. And Linda and Claire and the information officers have done some brilliant work with the care homes. And you're all here to help so when and if we do get the second wave, we can meet it. We have an outbreak plan. So this is available. You'll get the slides so you can follow the links. So this is something that we've all contributed to, but really Paul Fisher and Lisa McNally did the bulk of the work. And it's our local plan to say, how are we protecting the people of Sandwell against this pandemic? And actually, we're really proud because it was highlighted as a model of best practice by the Department of Health. So we're all feeling very proud of ourselves at the moment. But do have a look at that. It's a fascinating read. So really, just to wrap up this whistle-stop introduction to health protection. Health protection is public health in its immediacy. The decisions that we take today have life or death consequences in the next few days. A lot of public health is about something that might make a difference in 5, 10, 20 years time, and health protection isn't like that. It's about now, it's in its immediacy. There's been huge successes in recent years, but there are obviously massive challenges, not least of which is COVID-19. But it really is, it's fascinating, it is so interesting, it's so exciting, and it's a really fulfilling area to work in. So I want to say thank you, and I also want to say a massive welcome to health protection to you all, and thank you for all doing your bit. So that's the end of the session.